Welcome to the deep dive. Today, we're really aiming high. We're not just learning, we're setting out to achieve, genuine elite level mastery in echocardiographic anatomy of the heart. It's a field where tiny details matter hugely.
That's absolutely the goal.
Yeah.
We're digging into Hannah Sal and Thomas Matthews' chapter, but looking at it from, let's say, the cardiac surgical team's perspective. It's all about turning those echo images into really precise, actionable guidance for them.
Right, because the sources make it clear straight away. For cardiac surgery patients, echo isn't just one test. It's a vital tool used across three really distinct phases of care.
Exactly. It kicks off with preoperative imaging. And this part, well, it's just foundational.
Foundational how?
It's where you identify the true severity of the lesions,
Yeah.
You figure out if the patient is even a suitable surgical candidate. It guides the actual choice of intervention. Are we talking repair or replacement? Maybe a percutaneous approach. And crucially, it helps predict long-term outcomes. You look at the pre-existing ventricular function, and that tells you a lot. Without this kind of precise map, the surgeon is, frankly, flying blind.
And that initial map then carries right into the operating room itself.
Precisely. The ecosystem moves intraoperatively.
Right.
We use transoesophageal echo, or 2OE, right there in the OR for immediate real-time feedback.
Real time, wow.
Yeah. It confirms the initial diagnosis just before the intervention starts. It helps guide complex things like cannulation or, say, a transeptal puncture. And maybe most importantly, it confirms the functional success of the repair before the patient even leaves the operating table.
And the job's still not done then. Is it the scanner still crucial afterwards?
Absolutely. Postoperative imaging is essential.
Yeah.
You're assessing the immediate outcome, checking the function and anatomy of that new valve or repair, and you're detecting early complications, sometimes life-threatening ones.
Like what sort of things?
We're talking about ruling out cardiac tamponade. That's a surgical emergency, or spotting acute valve failure, maybe a new ventricular septal defect, right away. Speed is critical there.
Okay, let's step back for a second. Before we get lost in the heart's amazing architecture, we need to understand the basics of how we even see it. What's the fundamental physics here? How does this non-invasive imaging actually work?
Well, it all starts with the ultrasound mechanism itself. It relies on something called the piezoelectric effect.
Piezoelectric.
Yeah. The magic happens inside the transducer probe. It's packed with these specialized crystals. When you hit those crystals with an electrocurrent, they vibrate, they oscillate, and generate these high-frequency mechanical vibrations. Those are the ultrasound waves. And then they're sent into the chest.
So waves go out, travel through tissue, hit a boundary, like where muscle meets blood.
Exactly. Or blood meets an artery lining.
Yeah.
And then they reflect back.
An echo.
Precisely. That reflected energy, the echo, comes back to the same crystals. And now they do the reverse. They convert that mechanical energy back into an electrical signal. The system then measures two key things from that signal: location and brightness.
So location is just about timing, how long it took.
It's purely temporal, yes. The distance of the structure from the probe. That's determined simply by the time it takes for that ultrasound wave to travel out and then come back. Depth.
And the brightness, how bright or dark something appears.
That's its echogenicity. It depends on the difference in acoustic impedance between the two materials, right at that boundary where the reflection happened.
Acoustic impedance. Okay, so that difference is why, say, the heart muscle looks different from the blood inside.
That's a perfect example. Think of acoustic impedance as kind of like density, but specifically for sound waves. The bigger the mismatch in impedance, like between blood and a really bright prosthetic valve ring, or maybe some calcified tissue, the stronger, the brighter the reflection. That difference creates the contrast in our image.
Which brings us straight to that core challenge, doesn't it? The frequency versus resolution trade-off. Every skilled operator is constantly juggling this, right? Based on the patient or what they need to see.
It's the inescapable trade-off, yeah.
Yeah.
If you use lower frequencies, the waves penetrate deeper. That's good for seeing structures far away or in larger patients. But you sacrifice resolution, things aren't quite as sharp. Conversely, higher frequencies, which we love because they give you incredible detail, fantastic clarity, they just don't penetrate as deeply.
And for typical adult heart scans, there's a sweet spot we aim for.
Generally, yeah. We usually operate in the 2 to 7.5 megahertz range. The rule is you select the highest frequency you can get away with that still allows adequate penetration for whatever you're trying to examine, whether it's a standard surface TTE study or looking deep at the base of the ventricles.
And a proper comprehensive echo exam isn't just one type of picture, it's a whole toolkit. We use A mode, B mode, and crucially M mode.
Right. M mode or motion mode. It uses a single scan line, like an ice pick view, but sampled very, very rapidly. Its real power is its amazing temporal resolution,
Temporal resolution meaning?
meaning it tracks the movement of structures along that single line incredibly fast over time. It's fantastic for measuring things like how chamber size changes through the heartbeat or watching the rapid flutter of a valve leaflet.
Then we have the standard 2D echo, 2DE. That's the familiar pie slice image, right? Multiple scan lines making a cross-section.
That's the one, the tomographic section showing real-time anatomy. And increasingly, we're using 3D echo, 3DE, to capture the entire volume at once.
And it's not just about structure. We can see how things are moving, especially blood flow, with Doppler echocardiography.
Exactly. Doppler calculates blood flow velocity. It works by measuring the frequency shift of the ultrasound waves bouncing off moving red blood cells. Simple principle, blood moving towards the probe, frequency goes up, moving away, frequency goes down.
Okay, but how do we get from just measuring speed, velocity, to understanding how bad, say, a narrowed valve is? This is where the physics turns into practical hemodynamics, isn't it?
This is absolutely central to non-invasive assessment. It's the modified Bernoulli equation. We take the measured maximum velocity, v, and we use it to derive the pressure difference, the pressure drop, which we call delta P. The simplified formula we use constantly is delta P equals 4v22.
4 times velocity squared. That little equation is huge.
It's monumental. It lets us non-invasively calculate the pressure gradient across a stenotic valve or estimate pulmonary artery pressures. It turns simple velocity data into a hard number that tells us about clinical severity. It really is a cornerstone.
Absolutely essential. Okay, so we have the physics, the modes. Now, the 2 main ways we actually get these images: transthoracic, TTE, and transoesophageal, TOE. Same principles, but very different views.
Right. TTE is the standard, the go-to screening tool. You put the probe on the chest wall, easy, non-invasive.
But sometimes TTE just isn't enough. When do you have to switch to TOE, which is more invasive?
You need TOE when TT is non-diagnostic.
Yeah.
Maybe the patient has poor acoustic windows, could be body shape, could be lung disease getting in the way. Critically, though, TOE gives vastly superior views of structures located posteriorly in the chest.
Because the probe is right behind the heart in the esophagus.
Exactly. It cuts out all the interference from lungs and ribs. So we're talking about getting great views of the pulmonary veins, the whole descending aorta, the left atrial appendage, LAA, which is often where clots hide, and getting really clear artifact-free images of prosthetic valves or any cardiac masses.
So it's not just for difficult windows, it's actually better for certain structures.
Definitely. And beyond diagnosis, TOE is now indispensable for guiding and monitoring specific procedures. Think about things like TAVR transcatheter aortic valve replacement or complex mitral valve repairs done percutaneously. TOE is the real-time monitoring system in those cases.
Okay, let's pivot from the physics to the anatomy itself. Starting with the engine room, the high-pressure system, and the absolute powerhouse there is the left ventricle, the LV. So much pathology centers on the LV, #tag A. The left ventricle, LV.
Anatomically, the LV is interesting. It doesn't really have clear internal dividing lines. We usually describe it as having 3 functional parts: the inlet near the mitral valve, the outlet leading up to the aorta, and then the apex, the pointy bottom part, which is typically heavily trabeculated, meaning it has lots of muscular ridges.
And it has that classic ellipsoid sort of bullet shape tapering down. How thick should that muscle wall be normally?
In a healthy adult, you're looking at a wall thickness somewhere between 0.6 and 1.6 centimeters, usually thickest up near the base. The walls themselves have names based on location: the interventricular septum, IVS, medially, then the anterior, inferior, infralateral, and anterolateral walls. Knowing these is vital for assessing regional function.
Which brings us right to assessment. You need a comprehensive evaluation, imaging the LV from multiple angles, long axis, short axis, apical views, sometimes subcostal. And the sources stress this checklist: geometry, size, regional function, and global function.
That's the elite checklist, yes.
Yeah.
Regional function, how well each part of the wall is squeezing, is assessed using the standard 17-segment model. This is critical because those 17 segments map directly onto the territories supplied by the major coronary arteries.
So if one segment isn't moving well.
It points directly to a likely blockage in the specific coronary artery feeding that piece of muscle. It's incredibly valuable diagnostic information.
And heart disease can really mess with that nice ellipsoid shape. Let's talk about the main ways the LV morphology changes pathologically.
2 main patterns. First is global dilation. This happens in conditions like dilated cardiomyopathy or significant volume overload. The LV basically stretches out, becomes more spherical, more like a basketball.
And a sphere isn't a very efficient pump.
Exactly. Yeah. It leads to reduced systolic performance. And crucially, as it dilates, it pulls the papillary muscles outwards and apart.
The papillary muscles that anchor the mitral valve.
Right. When they get displaced, they tug on the mitral valve leaflets via the chordae, preventing them from closing properly. This causes functional mitral regurgitation. It's often a vicious cycle. The leak makes the ventricle dilate more, which makes the leak worse.
Okay, that's dilation. What's the second pattern?
That's the response to chronic pressure overload. Think severe aortic stenosis, or years of uncontrolled high blood pressure. The LV wall has to work harder to push blood out, so the muscle thickens. This leads to concentric LV hypertrophy. The muscle mass increases inwards, sometimes even reducing the size of the LV cavity itself.
Now, the classic measure of overall pump function is ejection fraction, or EF. How do we actually calculate that with echo?
We measure the volume of the LV cavity at its largest, end diastole, EDV, and smallest, end systole, ESV, typically from the apical views. We use a calculation method called the biplane method of disk summation, often called the modified Simpson's rule. It mathematically slices the ventricle into thin disks to estimate the total volume. Then the formula is simple. EF, EDV, ESV, EDV gives you a percentage.
But you flagged a warning earlier. This 2D calculation isn't perfect. Why is 3D echo considered superior for volumes and EF?
This is a key tip, yeah. The big hazard with 2D is apical foreshortening. It's easy to accidentally angle the probe so you're not imaging the true, absolute apex of the ventricle. If you cut the apex off, all your geometric assumptions for Simpson's rule are wrong, and your volumes will be underestimated, usually leading to an overestimation of the EF. 3DE captures the entire ventricle volume in one go. It overcomes the foreshortening problem and doesn't rely so heavily on geometric assumptions. So it generally provides more accurate and reproducible measurements of LV volumes and function.
Let's shift to acute, really dangerous stuff. What are the catastrophic mechanical complications we look for immediately after a major heart attack, a transmural MI?
You're scanning urgently for things that cause sudden collapse. First, rupture of the free wall of the ventricle. That causes blood to leak into the pericardial sac, leading to cardiac tamponade, often fatal very quickly.
Okay.
Second, rupture of the intraventricular septum, the IVS. That creates a hole between the ventricles, a VSD, usually causing acute heart failure. Third, rupture of a papillary muscle. Suddenly, the mitral valve isn't anchored properly, leading to acute severe mitral regurgitation, all surgical emergencies.
And this brings up a really important distinction professionals have to make, telling a true aneurysm from a pseudoaneurysm.
Yes, this is crucial. A true aneurysm is a weakened, bulging area of the LV wall that still contains all three layers of the heart muscle, just thinned out. It typically has a wide opening or neck connecting it to the main LV cavity.
And a pseudoaneurysm?
A pseudoaneurysm is actually a contained rupture. The wall is torn through, but the resulting bleed is walled off by pericardium or scar tissue. The key feature is a narrow neck relative to the size of the aneurysm sac itself. And importantly, the wall of the pseudoaneurysm sac lacks true myocardial tissue.
Why is that distinction so critical?
Because pseudoaneurysms have a much higher risk of complete rupture compared to true aneurysms. Finding one usually means immediate surgery.
Lastly, for the LV, let's not forget normal things that can look abnormal, the anatomical variants.
Right. We have to mention false tendons. These are quite common little fibromuscular bands that can stretch across the LV cavity, often seen near the apex. They are completely benign. The hazard is mistaking them for something serious, like pathological hypertrophy, or worse, a blood clot, a thrombus. Recognizing them as normal variants is key. Tag B, the mitral valve, MV.
Okay, let's follow the blood flow back from the LV across the inlet valve, the mitral valve, MV. It's a complex apparatus. What are the non-negotiable anatomical parts for surgical assessment?
Well, obviously the two leaflets, the anterior and the posterior. The posterior one is distinctively scalloped, having multiple segments. But just as important is the annulus, the ring the leaflet's attached to. It's D-shaped. The anterior part by the aorta is quite fibrous and fixed, but the posterior part is less well-supported, more flexible, and very prone to stretching to dilating. Then you have the chordae tendineae, the heartstrings, connecting the leaflets down to the two papillary muscles, the anterolateral and the posteromedial, which arise from the LV wall. The whole thing works together as a unit.
And for surgery, the way the leaflets come together, the coaptation is critical.
Absolutely. Yeah. Normally, the leaflets should meet, coapt, below the level of the annulus inside the ventricle. And you want to see a good zone of coaptation, ideally at least 5 millimeters deep, to ensure a good seal. We use multiple views, parasternal long axis, PSLAX, apical views, sometimes transgastric TG views with TOE to assess leaflet thickness, how well they move, and exactly where and how well they coapt.
The most common reason for MV surgery is leakage, mitral regurgitation, MR. And the language everyone uses is the Carpentier classification. Why is that system so dominant?
Because it's a surgical classification.
Yeah.
It categorizes MR based purely on leaflet motion, and that mechanism directly points towards the likely cause and, crucially, the potential surgical repair strategy. It's the framework surgeons think in.
Okay, so break down the types for us. Type I.
Type I is defined by normal leaflet motion. The leaflets themselves are moving okay, but the valve still leaks. Why? Could be a hole, a perforation in a leaflet. Could be the annulus is dilated, pulling the leaflets apart. Or maybe changes in the LV shape itself have distorted the geometry. Because the leaflets are fundamentally working, type IMR typically results in a central jet of regurgitation shooting straight back into the left atrium.
Got it. Then type 2, that's the classic prolapse, right?
Type 2 is all about excessive motion. This is where part of a leaflet billows back too far during systole. If the coaptation point itself actually goes above the level of the annular plane, that's true prolapse. If a leaflet segment is completely detached, maybe due to a ruptured chorda, and it's just flailing freely, we call it a flail leaflet, its tip often points right up towards the roof of the left atrium.
And the jet.
Critically, type 2 failure usually produces an eccentric jet. The regurgitant blood squirts off in an odd direction, typically away from the prolapsing or flailing leaflet. Seeing that eccentric jet is a huge clue that you're dealing with a type 2 mechanism.
Makes sense. And finally, type 3, restricted motion.
Type 3 is the opposite. The leaflets can't move enough. They're restricted. This can happen in two main ways. Type 3 is restriction during both systole and diastole, usually due to intrinsic leaflet disease like rheumatic heart disease causing thickening, calcification, and fusion of the leaflets. Type 3 is restriction primarily during systole. This is very common in ischemic heart disease.
How does ischemia cause restriction?
If you have a regional wall motion abnormality, say from a previous heart attack, affecting where a papillary muscle attaches, that muscle gets pulled downwards and outwards. This tethers the attached chordae and leaflets, pulling them down into the ventricle and preventing them from closing properly during systole. We call this tenting.
Okay, so if we see specific diseases, what are the classic echo findings? Rheumatic versus degenerative.
Classic rheumatic MV disease shows thickened leaflets, often with commissural fusion, the edges sticking together. You typically see doming of the anterior leaflet in diastole because its base is fused, but the tip tries to open. The posterior leaflet is often severely restricted. Degenerative disease, on the other hand, is usually about excessive motion-thickened, floppy leaflets, maybe elongated or ruptured chordae, leading to that prolapse or flail segment we talked about.
Let's switch gears slightly to mitral stenosis, MS, the narrowing. A normal valve is huge, 4 to 5 square centimeters. When does the narrowing become significant?
We start getting concerned when the area drops below about 1.5 centimeters Js. Severe MS is defined pretty strictly. A valve area less than 1.0 centimeters, and a mean pressure gradient across the valve greater than 10 millimeter Hg.
How do we measure the area?
Two main ways. The gold standard is planimetry, directly tracing the orifice area in a short-axis view during diastole. You literally measure the opening. The other common method uses Doppler to measure the pressure half-time, which can then be used to estimate the valve area. Planimetry is generally preferred if the images are good.
Now let's circle back to that absolutely critical hazard you mentioned earlier about assessing the LV when MR is severe. Why is EF misleading?
This is, possibly one of the most important takeaways for anyone dealing with severe MR. If the mitral valve is leaking badly, a significant portion of the blood the LV ejects each beat goes backwards into the low-pressure left atrium, not forwards into the high-pressure aorta.
Right, it's an easier path.
It's an easy pop-off valve. This artificially lowers the afterload on the LV, so the ventricle can maintain a normal or even high ejection fraction for a long time, even when the underlying muscle function is actually starting to fail. The EF looks deceptively good.
So relying on EF could lead you to delay surgery too long.
Precisely. That's why in patients with severe MR, the end-systolic volume, ESV, or the end-systolic diameter, ESD, of the LV are much better indicators of true underlying LV systolic function and contractile state. Once the ventricle starts to dilate, even at end systole when it should be smallest, that's a sign it's truly struggling, regardless of what the EF number says. That dilation often triggers the need for surgery. Hashtag Townsend is the AV.
All right, moving out of the LV through the outflow valve. The aortic valve, AV, 3 cusps, Right coronary cusp, RCC, left LCC, and non-coronary cusp, NCC. You mentioned their attachments create crucial relationships.
Absolutely vital, especially for surgeons. The NCC and LCC are structurally continuous with the anterior radial leaflet, that's the aorta mitral curtain. The NCC in particular sits very close to the membranous part of the interventricular septum, near the heart's conduction system. The RCC is close to the right ventricular outflow tract, RVOT. So working on the AV always carries some risk to these neighboring structures.
And the annulus isn't a simple ring.
No, it's more of a virtual ring defined by the lowest attachments of the leaflets. It's often not perfectly circular, and measuring it accurately is key for sizing prosthetic valves correctly.
In short axis view, we see that classic Mercedes-Benz sign when the healthy valve closes in diastole. Let's talk aortic stenosis, AS. Super common. What causes it typically?
In older adults, it's overwhelmingly degenerative calcification, wear and tear, leading to stiffening and narrowing. In younger patients, you think more about congenital abnormalities, most commonly a bicuspid aortic valve, having 2 leaflets instead of 3. But sometimes unicuspid or even quadricuspid valves can cause stenosis.
And severity grading. What defines severe AS?
The guidelines are quite clear. Severe AS is generally defined by a valve area less than 1.0 centimeters 4, OR, an aortic jet velocity, measured by Doppler, greater than 4.0 meters, OR, the most commonly cited hemodynamic criterion, a mean pressure gradient across the valve greater than 40 millimeter Hg.
Okay, but then there's that tricky situation, low gradient AS, where the numbers seem to contradict each other.
Yes, this is a major diagnostic challenge. You might have a valve that looks severely narrowed and calcified, maybe the area calculates as less than 1.0 millimeters, but the measured gradient is low, say less than 40 millimeter Hg, and the velocity is also low.
Why would that happen?
The most common reason is that the left ventricle itself is quite weak. It has poor systolic function. It simply can't generate enough flow, enough cardiac output, to create a high-pressure gradient across the narrowed valve, even though the valve is genuinely severely stenosed. This is called low-flow, low-gradient, severe AS.
So you can't just rely on the gradient in that case. What do?
You have to investigate further. The standard approach is a low-dose dobutamine stress echo. You give a medication, dobutamine, to stimulate the heart to beat stronger, increasing flow. If the gradient then increases significantly above 40 millimeter Hg while the valve area stays small, it confirms true severe AS. If the gradient stays low but the valve area increases, maybe the stenosis wasn't truly severe to begin with.
Any other tools?
Yes. Another very useful tool, especially if the stress echo is inconclusive, is a CT calcium score of the aortic valve. If the valve is heavily calcified, high calcium score, that provides strong evidence that the stenosis is anatomically severe, regardless of the flow dynamics.
Makes sense. What about the opposite problem? Aortic regurgitation, AR, or leakage? Again, classification by mechanism seems key.
It is, especially for surgical planning.
Yeah.
Similar to the mitral valve, we can classify AR mechanistically. Type I, functional AR, is when the leaflets themselves are essentially normal, but they fail to cope properly because the aortic root structure around them is dilated.
Dilated where?
Could be dilation at the level of the annulus, the sinuses of Valsalva, or the sinotubular junction just above the sinuses. This usually causes a central jet of regurgitation. Type 2 AR, excess motion, is due to leaflet prolapse, or maybe a tear or hole, fenestration, in a leaflet. This typically causes an eccentric jet. Type 3 AR, restricted motion, is when the leaflets are thickened, stiff, maybe calcified due to degenerative or rheumatic disease, and simply can't close properly.
And the surgical relevance here?
It's significant. Type I and Type 2 AR, where the problem is mainly root dilation or leaflet prolapse, rather than severe leaflet destruction, are potentially amenable to complex aortic valve-sparing surgery. The surgeon aims to repair the root and or resuspend the patient's own leaflets, avoiding a full valve replacement. So the detailed echo description of the root dimensions and leaflet mobility is absolutely essential for deciding if a valve-sparing approach is feasible.
Okay, we've covered the high-pressure left side. Now let's cross over to the right side of the heart. If the LV is the powerhouse, the right ventricle, the RV, seems like more of a geometric puzzle. It presents unique challenges. Hashtag A, the right ventricle, RV.
That's a good way to put it. Compared to the relatively simple, thick-walled, symmetrical LV, the RV is notoriously complex. Its wall is much thinner, only about 3 to 5 millimeters thick normally, and it wraps around the LV kind of like a crescent moon in cross-section. Functionally, we often divide it into 3 parts: the inlet, near the tricuspid valve, the apical portion, which is heavily trabeculated, and the smooth-walled outflow tract leading to the pulmonary artery.
And that weird shape must affect how it contracts.
Absolutely. Its contraction is very different from the LV's radial squeeze. The RV contracts predominantly longitudinally. Think of it more like a bellows, or like the free wall moving inwards towards the septum and the base being pulled down towards the apex. Anatomically, we identify it by key features: the tricuspid valve, which sits slightly closer to the apex than the mitral valve, those heavy trabeculations, the presence of the moderator band, a muscular band near the apex, and usually 3 or more papillary muscles.
Because it's so complex, you mentioned quantitative assessment is tough. How do we usually judge its size, say in the standard 4-chamber view?
Yeah, routine assessment of RV size is often more qualitative, especially with TTE. A rough guide is that the normal RV cavity should be no more than about 2/3 the size of the LV cavity in that view.
And when it gets bigger?
We grade the dilation. Moderate dilation is when the RV is roughly the same size as the LV. Severe dilation is when the RV cavity is clearly larger than the LV, sometimes even pushing the interventricular septum over towards the left.
And seeing a dilated RV immediately makes you think of
Overload conditions, either volume overload, like from a large atrial septal defect, ASD, or severe tricuspid regurgitation, TR, where too much blood is cycling through the right side, or pressure overload, usually from high pulmonary artery pressures, pulmonary hypertension, making it hard for the RV to pump blood out.
Given this complexity, you said getting precise volume numbers for the whole RV at once is often impossible, so how do we assess its overall function? Because RV function is a really important predictor of surgical outcomes.
Right, it's a critical predictor. Since full volumetric measures are challenging, we often rely on simpler, more reproducible 2D metrics. One common one is fractional area change, FAC. You trace the RV area in the 4-chamber view at end diastole, EDA, and end systole, ESA, and calculate the percentage change, ED, ESA, EDO 100.
Okay.
Another very widely used simple measure is tricuspid annular plane systolic excursion, TAPSE. You use M mode to measure how much the tricuspid valve annulus moves upwards towards the apex during systole. This is a measure of that longitudinal function we talked about, and despite its simplicity, it correlates pretty well with overall RV function.
Now, for the real pros, understanding how the septum behaves differently depending on the type of RV overload. That seems like a key diagnostic skill.
It absolutely is. This is subtle but crucial. Both significant pressure overload and volume overload can cause the interventricular septum, IVS, to look abnormal.
Yeah.
It might flatten out, or even bulge towards the left ventricle. But the timing of that abnormal motion tells you what kind of stress the RV is under.
How so?
In pressure overload, like severe pulmonary hypertension, the pressure inside the RV is high throughout the cardiac cycle, but it peaks relative to the LV pressure during systole. So you see the septal flattening or leftward shift happening throughout the cycle, but it's usually most pronounced at end systole. The septum looks D-shaped in short axis at end systole.
Okay, end systole for pressure overload. What about volume overload?
With volume overload, like a big ASD or severe TR, the RV is maximally dilated and filled during diastole. That's when the volume stress is highest relative to the LV. So the septal flattening and leftward shift are seen primarily during diastole. The septum might look relatively normal in shape during systole. Seeing that diastolic flattening points you towards a volume issue.
Interesting distinction. Is there a third pattern?
Yes, there's the septal bounce. This is a brief, sometimes paradoxical, jerky or bouncing motion of the septum, often exaggerated during inspiration. It suggests that the two ventricles are behaving independently, not influencing each other normally through the septum. The classic sign you see in conditions that restrict the heart from the outside, like constrictive pericarditis, #B, the left atrium, LA.
Moving superiorly now to the collecting chambers, the left atrium, LA. It sits quite posteriorly at the base of the heart. What are its main parts?
Anatomically, we think of it having 4 components. There's the main venous portion, which receives oxygenated blood from the 4 pulmonary veins, PVs. There's the left atrial appendage, LAA, that little outpouching. There's the vestibule, which is the area leading into the mitral valve. And then there's the part that forms the interatrial septum, IAS, separating it from the right atrium.
Tell us more about the LAA. It comes up a lot in clinical discussions.
It does. The LAA is this sort of finger-like or sometimes multi-lobed structure that projects anteriorly and laterally. Its inner surface is heavily trabeculated with pectinate muscles. Another structure nearby that can sometimes cause confusion on imaging is the posterolateral ridge, also known as the Coumadin ridge or ligament of Marshall. It's basically an infolding of tissue between the LAA and the left upper pulmonary vein.
And you mentioned TTE struggles with these posterior structures, so TAO is the key for LA assessment.
Generally, yes.
Yeah.
Especially for detailed views of the LAA and the pulmonary veins. You need those mid-esophageal ME views, scanning through different angles, typically 0 to 120 degrees, to really see the LA well.
Why is assessing the LLA so important?
Two main reasons. First, LA dilation itself, which is common in conditions like atrial fibrillation, AF, or mitral valve disease, or LV dysfunction, is an independent predictor of poor cardiovascular outcomes. Bigger LA often means more problems down the line. Second, and perhaps more acutely important, the LAA is the primary site, like over 90% of the time, where blood clots, thrombi, form in patients with AF.
Due to stagnant blood flow.
Exactly. When the atrium isn't contracting well, blood can cool and stagnate in the appendage. The first sign of this is often spontaneous echocontrast. You see this swirling, smoke-like appearance in the blood on echo. That indicates stasis. And if a thrombus forms, it typically looks like a well-defined echogenic, bright mass attached to the wall, most often within the LAA. Finding a thrombus, especially before a procedure like cardioversion, is critical.
Which brings us to a major imaging hazard, mistaking normal structures for thrombus.
This is a huge pitfall. Those pectinate muscles lining the LAA can be quite prominent and complex, and they can easily mimic a clot, especially if you only look in one view. Similarly, that posterolateral ridge can sometimes look like a mass. True mastery here requires using multiplanar 2D imaging, sometimes 3D echo, and using Doppler flow assessment to confirm that these structures are just normal muscle or tissue folds, not dangerous mobile thrombi.
Good point. And LA dilation isn't always symmetrical.
No, it often dilates asymmetrically, so just taking one linear measurement might not give you the full picture. It's better to measure dimensions in multiple planes, or ideally calculate the LA volume for the most accurate assessment of size. ###C, the right atrium and interatrial septum, IAS.
Okay. Across the septum, to the right atrium, ILA, it sits anterior and to the right of the LA. How do we identify it?
Key identifiers are its connections to the superior vena cava, SVC, and inferior vena cava, IVC, bringing deoxygenated blood back from the body. Internally, the defining feature is the crista terminalis. This is a C-shaped muscular ridge that runs vertically along the posterolateral wall, separating the smooth-walled venous part, sinus venerum, from the rough trabeculated anterior part, which includes the RA appendage. You also see the opening of the coronary sinus CS, which drains blood from the heart muscle itself, located between the IVC orifice and the tricuspid valve. It's often guarded by a little flap called the Thebesian valve.
How do we assess RA size?
Usually with planimetry, tracing the area, and the TTE apical four-chamber view, an area greater than 18 centimeter is generally considered enlarged. For more detailed structural assessment, especially if you're guiding procedures like SVC cannulation for bypass or performing a transeptal puncture to get to the left side, the TOVI bicaval view is invaluable. It shows the RA, the SVC, and IVC entering it, and the interatrial septum very clearly.
Now, you mentioned hazards in the LA. The RA seems to have even more potential pitfalls, normal things that look like pathology.
Yes, the RA is famous for its embryological remnants that can mimic serious problems. This is absolutely critical knowledge for avoiding misdiagnosis. There are several key ones.
Go on.
The Eustachian valve is a remnant flap related to the IVC opening. It can sometimes be large and mobile. The Chiari network is a delicate, lace-like, highly mobile network of fibers, often originating near the IVC or CSs. It can look dramatic, almost like a vegetation or thrombus flapping around, but it's benign. The crista terminalis itself, that muscular ridge, can sometimes be quite prominent and mistaken for a mass. And even the Thebesian valve guarding the coronary sinus can occasionally be prominent.
So Eustachian valve, Chiari network, crista terminalis, these are the big ones to know.
Absolutely. Recognizing these as normal variants can save a patient from a lot of unnecessary anxiety and further invasive tests. They are frequently mistaken for thrombi, vegetations from endocarditis, or even tumors by less experienced imagers.
Okay, finally in this section, the wall between the atria. The interatrial septum, IAS, what's its structure?
It's formed from several embryological components merging, mainly the septum primum, a thin flap covering the fossa ovalis, and the thicker septum secundum surrounding it. There's also a small contribution from the AV canal septum inferiorly.
And we need to distinguish between a common functional finding and a true hole, a defect.
Right. We need to differentiate the functional patent foramen of Vail, PFO, from a true atrial septal defect, ASD. A PFO is basically a tunnel-like potential opening in the fossa ovalis region where the septum primum hasn't fully fused to the septum secundum. It allows intermittent shunting of blood, usually right to left, especially with straining. It's present in about 25% of the normal adult population and usually doesn't need closing unless it's linked to specific problems like stroke.
And a true ASD.
An ASD is a persistent hole, a true deficiency in the septal tissue, allowing constant shunting, usually left to right initially. They're classified by location. Ostium secundum defects are the most common, located right in the fossa ovalis region due to a deficiency of the septum primum. Ostium primum defects are located lower down, inferiorly, near the AV valves, and are often associated with abnormalities of the mitral and tricuspid valves, part of an AV septal defect complex.
Is there another type?
Yes, the sinus venosus defects. These are located superiorly near the SVC entry, or inferiorly near the IVC entry. They're outside the fossa ovalis region. TOE is absolutely critical for assessing all types of ASDs, determining their size, shape, the surrounding tissue rims, crucial for deciding if closure with a device is possible, and their relationship to adjacent structures. This is especially true for sinus venosus defects, which are very often associated with anomalous pulmonary venous drainage, pulmonary veins connecting to the right atrium instead of the left, which must be identified before any repair.
All right, let's look at the last valve, the inlet to the right ventricle. The tricuspid valve, TV. Surprisingly, it's actually the largest of the 4 heart valves by area, isn't it?
It is, yeah. Normal area is quite large, around 7 to 9 square centimeters. It has 3 leaflets named based on their location: anterior, usually the largest, posterior, and septal, attached to the interventricular septum.
What are the key features that help distinguish it anatomically, especially from the mitral valve?
2 main things. First, the tricuspid annulus, the ring it sits in, has very little fibrous tissue compared to the mitral or aortic valves. This makes it much more prone to dilating, to stretching when the right atrium or ventricle enlarges. Second, a key differentiating feature on imaging is its position relative to the mitral valve. The septal leaflet of the tricuspid valve is typically inserted slightly closer to the apex of the heart than the anterior mitral leaflet.
There's a specific measurement for that.
Yes, for the professional, we quantify that apical displacement. Normally the difference is small, but a displacement of the septal TV leaflet greater than 8 millimeters per square meter of body surface area, BSA, is considered abnormal and is characteristic of Ebstein's anomaly.
And you mentioned the annulus dilates easily. Is there a size threshold for that?
Yes, generally an annulus diameter greater than 35 millimeters measured in diastole is considered dilated and abnormal. This often signals potential or actual functional regurgitation.
Which brings us to tricuspid regurgitation, TR. You said it's usually secondary.
Overwhelmingly, yes. Most TR we see is secondary or functional. It's not primarily a problem with the valve leaflets themselves. Instead, it's caused by conditions that raise pulmonary artery pressures or cause the RV or RA to fail and dilate. This dilation stretches the tricuspid annulus, pulls the leaflets apart, and prevents them from coapting properly. This usually results in a central jet of regurgitation.
But sometimes the problem is with the valve itself. What are the main causes of primary TR?
There are a few distinct causes to recognize. First, Ebstein's anomaly, that congenital condition we just mentioned with the excessive apical displacement of the septal leaflet. The leaflets are often malformed too. Second is carcinoid heart disease. This is a rare condition where hormone-secreting tumors elsewhere in the body release substances that cause fibrosis, particularly on the right-sided heart valves. The tricuspid leaflets become thickened, retracted, and rigid, leading to both stenosis and regurgitation. They look like they're plastered open.
Any other primary causes?
Third, increasingly common is iatrogenic damage, often from pacemaker or defibrillator leads. A lead passing through the tricuspid valve can sometimes perforate a leaflet or impinge on it, preventing proper closure and causing significant TR.
What about tricuspid stenosis, TS, narrowing of the valve?
Much rarer than TR. Usually caused by rheumatic disease, almost always affecting the mitral valve too, or that carcinoid syndrome we discussed. Clinically significant TS is suggested if the mean pressure gradient across the valve is greater than 5 mmHg.
And a key imaging challenge or hazard for the TV?
The main one is that because of the complex 3D orientation of the 3 leaflets, none of the standard 2D echo views can show you all 3 leaflets simultaneously. You see different combinations in different views, and because the ultrasound beam is so thin, even a tiny tilt of the probe might bring a different part of a leaflet, or a different leaflet entirely, into view. So you really have to systematically sweep through multiple planes and mentally reconstruct the valve to be sure about the location and extent of any pathology. hatch the aorta.
Okay, let's wrap up with the great vessel leaving the heart, the thoracic aorta. How is it divided anatomically?
We usually divide it into segments. Starting at the heart, you have the aortic root, which supports the aortic valve leaflets and extends from their base up to the sinotubular junction, where the bulbous sinuses transition to the tubular aorta. Then comes the ascending aorta, traveling upwards. Then the aortic arch, which curves backwards and gives off the three major branches to the head and arms: brachiocephalic, left common carotid, left subclavian. Finally, the descending aorta, which runs down through the thorax.
How well can we see all this with echo?
TTE has limitations. You can get decent views of the aortic root and the proximal ascending aorta from peristernal views, maybe glimpse the arch from the suprasternal notch view, and sometimes see a bit of the descending aorta behind the heart. But for a comprehensive evaluation of the entire thoracic aorta,
You need something else.
COE is definitely the ultrasound modality of choice. It gives excellent views of the root, ascending aorta arch, though sometimes the distal arch is shadowed by the airway, and especially the descending aorta, which runs right alongside the esophagus. However, even TOE has some blind spots. For truly complete sizing and assessment, especially of the entire arch and distal ascending aorta, CT or MRI are often considered the gold standard imaging modalities.
For the elite professional doing echo, precise measurements of aortic size are critical, especially for determining surgical triggers. What are the key metrics?
Right. Aortic size normally varies with body size, BSA, and age. The source materials provide detailed tables, but as rough examples for indexed values, the ascending aorta might normally be around 13 PMN, 1 tex millimin 22 BSA. The sinus of Valsalva section is typically the widest part. Dilation and aneurysm occurs when the structural components of the aortic wall weaken, could be due to genetic conditions like Marfan syndrome, inflammation, aortitis, or just degenerative changes over time.
And there's a critical size threshold where surgery is recommended even without symptoms?
Yes, prophylactic surgery to replace the dilated segment is generally recommended when the maximum diameter reaches 5.0 to 5.5 centimeters, or sometimes lower thresholds indexed to BSA or in specific genetic conditions. This is because the risk of catastrophic aortic dissection, a tear in the inner lining, or outright rupture, increases dramatically above this size.
And if a dissection does occur, what does it look like on echo?
The hallmark is seeing the intimal flap, the torn inner layer flapping within the aortic lumen, separating the true lumen, where blood flows normally, from the false lumen, the channel created by the dissection. Identifying the flap and differentiating the lumens is critical.
Finally, what are the key tips or hazards when imaging the aorta with echo? Things that can lead to major errors.
3 big ones. First, measurements must be made perpendicular to the aortic walls, usually leading edge to leading edge. If you measure obliquely across a curved vessel, you will overestimate the diameter, potentially leading to unnecessary surgery.
Okay.
Second, and this is vital, a normal TTE study absolutely does not rule out aortic dissection. TTE simply cannot see large portions of the aorta well enough. If dissection is clinically suspected, you need TOE or CT MRI urgently. Relying on a negative TTE can be fatal.
Critical point. And the third hazard.
A really nasty artifact pitfall. Reverberation artifact, especially from a thickened, somewhat calcified aortic wall, can sometimes create linear echoes within the lumen that tragically mimic the appearance of a true intimal flap. Mistaking artifact for dissection could lead to a completely unnecessary high-risk emergency operation. Careful technique, multi-angle views, and correlation with other modalities are essential if there's any doubt. Wow, we have covered an immense amount of detail today, really diving deep to try and reach that elite level of understanding from the physics right through to the surgical implications of subtle anatomical findings and potential pitfalls. Let's just quickly pull together some of those absolutely critical expert-level caveats that really separate the master imager from the novice.
I think one key takeaway was recognizing the inherent limitations with the right ventricle. Its complex crescent shape makes full quantitative assessment really challenging. True expertise means understanding those limits and relying more on things like longitudinal function metrics, TPSE, FAC, and importantly, the pattern of septal motion. Right, that septal motion distinction was huge. Pressure overload flattening the septum most in end systole versus volume overload causing that diastolic flattening. Recognizing that tells you so much about the underlying physiology.
And definitely, knowing those right atrial anatomical variants, the eustachian valve, the Chiari network, the crista terminalis, remembering those 5 key mimics is crucial to avoid calling normal anatomy dangerous pathology.
And back on the left side, maybe the most crucial hemodynamic point. why ejection fraction can be so misleadingly optimistic in severe mitral regurgitation, and why focusing on the end systolic size, the ESV or ESD, gives you a much truer picture of the underlying LV function in that specific setting.
Absolutely. Let's just hammer home that mastery with a quick fact check based on what we covered. What's the mean valvular gradient criterion often used for defining severe aortic stenosis?
Mean gradient greater than 40 millimilli Hg.
Correct. Now, which of these is typically not considered a direct mechanical complication of acute myocardial infarction, ventricular septal defect, papillary muscle rupture, or left ventricular hypertrophy?
Okay, that would be left ventricular hypertrophy. That's a chronic adaptation, not an acute rupture event.
Right again. Which of these is not a normal anatomical variant you might encounter in the right atrium? A Chiari network, a crista terminalis, or a secundum atrial septal defect?
A secundum ASD. That's a true hole, a pathology, not a normal remnant.
Perfect. And last one. Which of these conditions does not typically cause that abnormal, paradoxical, or flattened motion of the interventricular septum we discussed? RV pressure overload, RV volume overload, constricted pericarditis, or mitral regurgitation?
That would be mitral regurgitation. While it affects LV loading, it doesn't directly cause those classic RV-driven septal shift patterns seen in the other three.
Exactly. This really highlights an important point. When you're dealing with such sophisticated imaging, the risk of misinterpreting either normal variations or inherent technical limitations is actually quite high. Real mastery isn't just about spotting the obvious pathology. It's about deeply understanding these tips and anatomical hazards, knowing the limitations, and knowing when maybe you need another imaging modality to be certain.
We spent a lot of time discussing the RV's complexity and the challenges in fully quantifying its function, even with advanced echo. Yet we know RV function is a powerful independent predictor of long-term survival after cardiac surgery. So here's a thought to leave you with. What currently untapped physiological metric, something beyond the scope of our current standard 2D or 3D echo measurements, may be related to the intricate mechanics of myocardial strain, or perhaps the coupling between electrical activation and contraction might hold the key to the next leap forward in predicting surgical outcomes related to the right ventricle.
That's definitely something for you, our listeners, to ponder as you continue to build on this deep dive towards true mastery.
Until next time, keep diving deep into the data